I didn't expect to give you this presentation, so I beg your pardon for the slides and if I'm a little bit repetitive. But I'm showing you the data of the hepatitis A epidemics that we had in Pavia last year. And I'm showing you also some data from almost the last decades. We investigated our reports of hepatitis A hospitalizations. So my colleagues has already shown you some basic information about hepatitis A epidemics, and I think the most interesting pictures are the first two that gives us an explanation of the situation we experienced last year. Hepatitis A was once a common disease, especially in the childhood, but now, thanks to the increase in the hygiene, in the healthcare situation, it has become a rare disease, an uncommon disease. And so in the population, an antibody against hepatitis A title decreased, and the population became susceptible to the infection. And you can see in the second picture, especially in the countries of North Europe, the antibody title is really low. So we have a big population susceptible to an infection, and we had, at least last year, a group of patients, of people, with the infection moving across the continent. And so we experienced this enormous spike in the cases that it's reported in the third picture that Professor Poti already shown us. And I want to point out the ratio between male and female and the prevalence of male cases. These are the data of the Pavia 2017 outbreak, and we have the same prevalence of male against female. Almost 86% of patients were male. You can see many clinical data at admission, discharge, and during the outpatient clinic evaluation we performed almost 1 month after the discharge. And interesting are the the presumed transmission ways of the infection. 60% of our patients reported the consumption of contaminated food. Probably it presumed that they contracted the infection by this way. But we have a large portion of patients that are MSM, and they reported as the most probable way of infection some sexual intercourses. We had also 2 cases of infection transmission through sexual intercourses in a heterosexual couple, and 2 patients that contracted infection through the sharing of infected needles, so during intravenous drug use. And it's interesting to look at the co-infection that the comorbidities presented by our patients. We had 5 patients with HAV and 2 patients with chronic hepatitis B and chronic hepatitis C. You can observe the different cases per month. So we had the greatest number of cases in the spring of 2017, and in contrast with the normal epidemiology of hepatitis A that normally gives us the most of the cases at the end of the summer. You can look at the comorbidities, and we perform a sub-analysis of the comorbidities in MSM versus non-MSM. So HIV was most common. 80% of the HIV patients were MSM. Chronic hepatitis C was present only in non-MSM patients, and chronic hepatitis B was shared in equal manner between the 2 groups. We looked at the pre-2017 data, so we looked at the period from 2009 to 2016, and we observed 31 cases of hepatitis A, And in this situation, the ratio between male and female was different. Female were more represented, and male was still the greatest part, but the difference was less important. And we had less data about the transmission. So in 42% of cases, we cannot say which one was the transmission way. But in food is retained, the consumption of contaminated food is retained to be the causes of almost 55% of the infections. And we had only a slight 3% of patients that reported MSM as a possible role in the infection. And you can observe at the bottom the different cases per year, and it's clear the difference against 2017. So I told you our data, and I think that we, as Professor Puoti said before, for the epidemic in Milano, they didn't experience any severe liver decompensation. They didn't need any liver transplantation, but for sure the economic burden was not irrelevant. So for sure it's essential to vaccinate our population, our patients. Thank you.